This UCSD TV program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest programs.
I'd like to welcome you to the Rady Children's Hospital and UCSD Department of Pediatrics Grand Rounds, and it's also the 17th annual Lenore Hamburger Lectureship. This year, our Lenore Hamburger speaker is Dr. Hannah Valentine. She is Chief Officer of the Scientific Workforce Diversity at the NIH and also a Senior Investigator at NHLBI in Bethesda. Prior to this, she was Dean of Diversity at Stanford. She actually was born in Gambia, grew up mostly in the UK, and actually got her undergraduate medical training, MD and PhD, and medical internship, and the beginning of her cardiology fellowship, all in the UK at London University and Hammersmith Hospital. And then went for further training in cardiology at Stanford, where she stayed for 30 years. Her research interest has focused mostly on heart transplantation, with the focus on the causes and the treatment of allograft failure. She's published over 160 articles, many in very high-impact journals, 10 book chapters, and she's given over 100 lectures all over the country and all over the world. And she's also won numerous awards. Please welcome Dr. Hannah Valentine.
Thank you, Dr. Hoffman, for that lovely introduction. I must say I'm delighted and indeed very honored to be invited to give this lectureship today. I've seen the audience many people whom I know well who've been friends and colleagues through the years. And since I've spent so much of my time and formative career in California, Dr. Hoffman, I just wanted to point out that I didn't spend 30 years in training. I went to California to Stanford at the end of my clinical cardiology training for what was supposed to be 1 year to get my BTA. And if you don't know what that is, it's Been to America. And that ended up to be 30 wonderful years. So, and then, of course, 2 years ago, I was recruited to the NIH to lead their diversity efforts. And I'm not going to be speaking very much about what we do there, but just to say that these new efforts of NIH in diversity are really an example of how the great commitment there is to addressing this issue. And we are really reframing the language around diversity as more as an opportunity to engage the entire intellectual workforce in the United States to this science endeavor. We recognize that that the diversity of thought, diversity of perspectives, diversity of experiences has a great potential to enhance the science itself. So while the evidence for that needs to be buttressed with regards to science, there's a lot of evidence outside of the scientific field that points to the fact that when you have diversity in teams, you're much more likely to solve complex problems. And given the complex problems that face health and health disparities in particular, we think that ensuring that our workforce is diverse, truly diverse, will support the NIH mission. And I'll be happy to take questions about that later on. But what I'd like to do is, in this lecture, is to focus on the science, the area in which I have worked for the last 30 years or so. I'll start, this is in the field of heart transplantation. I'll start by presenting a case, indeed a pediatric case initially. I'll point to the medical need for why it is we need these newer technologies brought rapidly to the clinic for the care of this particular patient population. I'll talk about what this new idea is, or relatively new idea. In fact, it's not entirely new. It's just that we now have ways of using technologies for measuring cell-free DNA in a quantitative way. And I'll point to how that can ultimately result in really personalizing the care. And we'll talk about future directions. So this is a patient who was 29 by the time I met her, but she'd already had a heart transplant 17 years ago. And it was for familial cardiomyopathy. In fact, her brother had presented with cardiac failure at the age of 11 and was not taken care of rapidly, unfortunately died. She had a twin sister, and both of them presented ultimately with heart failure. And both of them had tremendous care at Texas Heart Hospital, actually, where they both underwent heart transplantation. And they did extremely well for 17 years. Ultimately, she relocated to the Bay Area with her husband, and we met her at Stanford when she was 3 months pregnant. She did very well. Her initial studies were all normal. She had normal cardiac function and eventually gave birth to a baby uncomplicated. And I'd just like to show you her echocardiogram when we saw her. And for those of you who are not used to looking at this, this is the 4-chamber view. The apex is the left ventricle. And what I'm trying to show you here is that the contractility is very good. So she's presenting, she has normal cardiac function at the time when we first see her, ejection fraction of 65%. Unfortunately, a few months after her delivery, she presents in severe heart failure and cardiogenic shock. Her ejection fraction is 25%. Her biopsy actually only shows mild rejection. But she does have HLA-positive antibodies, which are actually directed to the HLA type of the child. So what had happened is that the HLA that should develop antibodies to the child that, because of the difference with her husband. And this case has been reported, and it's not the emphasis of that, but just to point out that she did, in fact, have moderate coronary artery disease through the workup. And so we started her on heart failure regimen and put her for a retransplant. And here you see is the original echocardiogram on the left-hand side, and here when she presented with a markedly reduced ejection fraction. Just look at the borders of this endocardial borders and how little it's contracting in, and you can see the problem that we're faced with there. And this is the parasternal long axis view, where you can see that it's the thinning of the septum and really quite severe cardiac dysfunction. This is her coronary angiogram, and what I'm attempting to show you here is that this is the injection into the left anterior descending coronary artery. And if you look round about here, you're seeing a lot of really poor perfusion of the vessel distally, and a lot of it taken away with the peripheral vascular disease that we see so typically of transplant vasculopathy. I'm just showing you this because to emphasize one of the problems that we have with these patients is that the coronary artery disease long-term, it's very difficult to diagnose even by coronary angiography. And this is an example of another patient that I took care of, and I think any cardiologist will say that that coronary angiogram looks reasonable, but when you look here with an intravascular ultrasound, you see all of that is thickened plaque, which shouldn't be there. So the angiogram grossly underestimates this disease. So it's not surprising that our patient, in the way that she presents, with severe coronary disease that has gone undetected. And this further emphasizes this difficulty in diagnosing this problem of coronary disease. You can see again here in this section here with a coronary, intracoronary ultrasound, you can see already there is plaque formation around here. And by coronary angiography, you wouldn't have thought that there was anything going on at this level here, significant plaque thickening already. And then at C, even where the coronary angiogram looks normal, there is already some severe thickening of the intima and and diminution of the vessel dimension. This is to show you how this can progress with thickening at left ventricular hypertrophy. And right about here, you can see that the coronary arteries are thickened even on gross pathology with a real diminution of the size of the artery. And what is I'm attempting to show you here, that this is an inflammatory process. There is some tremendous thickening of the internal lining of the vessel wall. There is intimal proliferation as well as inflammatory response. So luckily, she received a heart, and this is the echocardiogram of the retransplanted heart, which is now functioning beautifully. And she went on with her life to do very well, and serving now very frequently as an advocate for transplantation. And here is her daughter. Here's the patient at 1 year post-transplant, doing extremely well, and that was about 6-7 years ago. We were just delighted by this. But this is a major problem, isn't it? And if you look at this is to show you the median survival of pediatric heart transplants throughout. The median survival is 13 years. That is the time at which half of the patients will be no longer alive, shown in the blue line here, and then broken down by various age groups, with the youngest having the best. So while they are doing well for overall survival, it's not optimal, and we need some other ways of managing them. And the first challenge is how we manage patients for detection of acute rejection. And it's classically, the gold standard is using an endomyocardial biopsy, where we go through the internal jugular vein here. I've done that must have done thousands of these myself. It is invasive, as you all know. It can result in damage to the tricuspid valve, in perforations, and the concordance of the biopsy reading between pathologists is not great, 58%. And beyond that, it is very expensive to do these procedures. So a lot of my research has been focused on coming up with a non-invasive way of monitoring rejection after organ transplantation. And this is particularly relevant, obviously, for the pediatric population. Moreover, a lot of the time, the rejection is now asymptomatic, and by the time you wait until you see evidence of heart failure, it's really too late, akin to the patient. So what can we do about that? So this idea that we might use donor-derived cell-free DNA has come about, and I'll go through what the technology looks like, but just a few facts about why it is that the cell-free DNA might be helpful. Actually, we all have quite a lot of cell-free DNA circulating in the blood as a result of turnover of a number of different types of cells. It can be found in the urine, plasma, saliva, and many other fluids. So we can get access to it to measure that baseline level of damage to tissues that's going on. It's generally double-stranded, but I'll show you evidence that microbial DNA can be also targeted to be picked up, and it's single-stranded. And it is circulating as mononucleosomes and cleared with a relatively short half-life, as shown here. So there is a history of using cell-free DNA for diagnosis. So like most things that we come to in clinical research, if you search the literature, you'll find that some work has already been done. It's been used for prenatal diagnosis and for determining fetal sex. A big area where it's being used is as a cancer biomarker. And many studies have shown that just the average total cell-free DNA in the circulation can be a marker of a cancer. And it's been used now. There's a number of studies for staging and assessing response to therapy. in your own field. Here it's been used in autoimmune diseases and for measuring tissue injury following stroke, myocardial infarction, and finally for viral infections. So when we came to this, we were wondering about how this could be applied to transplantation. And it seemed like sort of that low-hanging fruit. Here you have 2 genomes, and perhaps you can be able to detect what's coming from the donor as opposed to what's coming from the recipient. But in fact, these ideas were already in the literature. In renal transplants in the late 90s, they started looking at donor-derived cell-free DNA in the urine. And later on, looking for the amount of the Y chromosome in a patient who was female and received a kidney from a male donor. So you can see the genesis of these thinking had already been in place when we got into it. And in fact, this is when I heard about this work, it's really quite interesting how when you're in an environment, in an institution where interdisciplinary research is supported and fostered, how these things can happen. So Steve Quake was recruited to Stanford and very soon after published this paper for the non-invasive diagnosis of fetal aneuploidy using shotgun sequencing. That is, taking blood from the mother and be able to pick up sequences that have crossed the placenta and entered the circulation. And they reported that this was a very effective way. And I remember the moment reading this paper in my office and recognizing that Steve's office was just across the way at the Clark Center, setting up a meeting with him and bringing up the idea that maybe this technology could be applied to the patient populations that we were interested. And here's was his quote. Essentially, the organ transplant is a genome transplant. And of course, he predicted, as I did, that this would be a very effective way of monitoring rejection. And in fact, we set about doing a proof of concept experiment, which was published in PNAS, using actually archived blood specimens that we'd had around for quite a while, serum specimens from transplant patients. And that then led to a bigger study of 60 patients and 500 samples, which was ultimately published last year in Science Translational Medicine. And then as a consequence of all of this, beginning to look at for microbial sequences and that implication, and I'll talk about that in a moment as well. And Steve, together with Eric Topol, wrote this article last year about this, a stethoscope for the next 200 years, referring to this technique and to all other techniques because of the specificity of DNA and RNA sequencing and how that can be brought to bear in diagnosis of all kinds of diseases. So here's the technology that I'd like to spend a few minutes telling you about. It is actually, we use SNPs, positions in which the donor and recipient are homozygous within a single base pair, present in both alleles, and that allows for discrimination between donor and recipient-derived sequences. And so what you see here, as I mentioned before, there are over 1 billion fragments of cell-free DNA per mil in the plasma circulating at any one time, coming from the recipient, demonstrated here in red. And when you put in a heart, what you can see is, in fact, as represented by green, as the organ gets damaged, you can see more and more sequences coming from the transplanted organ. And the big question to us at that time, 3 years ago, could you measure the proportion of donor-derived DNA to recipient, and that give you a marker of injury, and early injury at that? And as I mentioned, the answer to that question was yes, through using the archive specimens that we had. And here, what we're showing you here is a % donor DNA in months post-transplant. And in a situation where there was no rejection, you had low levels of less than 1% of the donor-derived DNA compared to the recipient circulating DNA. In contrast, at the beginning of rejection, you see a gradual rise in the DNA from the donor, as shown in this section and there as well. So here we thought we had demonstrated proof of concept, but that was only in 7 patients and in 50 samples. So clearly we need to do more. And just a little bit more about the technology. You genotype the donor and recipient, and there are now approaches to circumvent the need for that, and we can talk about it. Collect the cell-free DNA from the plasma. Perform shotgun sequencing to identify the reads with donor and recipient SNPs, and then you calculate the percent DNA, and this is what it shows. And this is a graphic from the article that was ultimately published in Science Translational Medicine. And just to get into the details of it here, these are the SNPs from the done pre-transplant from the donor and the recipient. And you will notice that here there is a difference, the CG here, which does not appear here. And then you see it, you collect the samples, and you can then follow it here and then perform the sequencing and calculate a percentage. So what was the study design as shown here? Notice we made a concerted effort to include pediatric patients. So it was half a quarter of the population there, a third of the population, 21 pediatric patients. Pre-transplant, you collect the sample, purify the sequence, and sequence the cell-free DNA, and then they calculate the fraction of donor-derived DNA and compare to the grade of biopsy. And here's what we would expect in the absence of rejection. What you see is that immediately after transplant, of course, as might be predicted, the percentage of the donor-derived DNA is relatively high. You can see up to 10% compared to circulating, but there's a rapid decay, and bear in mind this when I talk about lung transplant in a moment, and then there's quiescence here in the absence of any further injury. In contrast to that, here is a patient who develops a rejection episode right here by endomyocardial biopsy, and then following treatment, it declines. Again, confirming the results that we had published in the proof of concept experiments. And this particular patient is a pediatric patient, this particular example. Often we're plagued with not only cellular rejection, but antibody-mediated rejection. And so in this early phase, this patient was diagnosed with cellular rejection through the 2R, meaning there is evidence of myocyte necrosis. And you can see the rise in the fraction of the donor DNA. The patients get treated with high-dose corticosteroids. There's slight decline, but to our great concern, we see a rise in the fraction of donor DNA, and that's coincident with a biopsy that shows now antibody-mediated rejection, patient treated again, and so forth, and that's how you follow this. And I think that mirrors the time course very nicely. And so for the 60 or so patients that were in the study, we've divided this into the quiescent, that's no rejection, mild rejection, and moderate severe rejection. And you can see the fraction of donor-derived DNA. But I think this is the most telling over here, where we try to calculate the receiver operating characteristics. And this is when you have a new test, you've got to be certain that the true false positive rates and the true false positive and true false negative rates should, you plot them out here, and if it's absolutely correlating, then it should be a straight line. But here the AUC is 0.825, which is really not bad at all, especially when we know that many of the false positives turn out to actually be not false positives, but in fact that the biopsy was incorrect. So I put this up here because it really points to the pediatric population. If you calculate those ACUs over time, there's a variation with a time post-transplant. And here, what I'm showing you here is the pediatric, the ACUs by years, by age post-transplant. And you can see that the ACU is particularly high for pediatric patients, and shown over in this slide here, it's 0.92. So this is a very sensitive and specific way of looking at this, we believe, and but will require the next set of studies, which is a further external validation, bearing in mind that this just comes from one center, and a clinical utility study. So this brings us to the question of, if this works in heart, can it work in other organ transplants? And the concept, conceptually, the answer to that should be yes. And we have data around the 4 lung transplants that suggest that this will work there as well. So why lung transplants? Well, in contrast to heart transplantation, the outcome following lung transplantation is particularly poor. It's inferior. The probability of survival at a year is only 80%, and the median survival rates are much lower. I showed you median survival rates of 11 years or so for the heart transplant, and here it's about 6 years. So we really believe there's a lot of injury that is immune-mediated going on that we are not picking up, that we could do a better job in the lung transplant field as well. So we have, within this cohort at Stanford, been following these patients using donor-derived DNA technology. And I put this up to show you 2 distinct patterns. That is the type of decay early post-transplant. So here in red is the heart decay, which I already showed you, where the percent DNA is rather high at the beginning, but there's a rapid decline, and then it remains low if there is no further injury. In contrast with the lungs, and this is better depicted down here, you will see that there is a much slower decay, and a first phase and then a second phase. And this raises the question of whether or not these grafts are getting in there already more injured, and because they're more injured, they are more prone to the activating the inflammatory responses. Or whether because of infection, because they are already infected, that they are already prone to injury and are more damaged and remain more damaged throughout, and that is impacting the long-term outcome. We don't know the answers to that yet, but in terms of acute rejection, just one slide here to show you normal and severe. This, the broad percent fraction being higher in the severe rejection, and the AUC, again, suggesting that this might be a good and sensitive way of following lung transplant. So a lot more work needs to be done in the lung transplant field as well, but these are the early proof of concept experiments that we believe are really helpful. Let's shift gears now for the next while on the issue of following patients for infection. We are really challenged in organ transplantation because of this narrow therapeutic window where we can, when we treat to prevent rejection, but we leave the patients open and prone to infection. So we've got to find that therapeutic window where we give enough immunosuppression to prevent rejection, but not stimulating or not enhancing the possibility of infection. And so this becomes quite problematic because there is not a specific test that tells us the level of immunosuppression. And now, of course, we know there's a wide variation in how individuals respond to individual immunosuppressive drugs. So, for example, African Americans will metabolize the calcineurin antagonist, which is the mainstay of immunosuppression, in a different way from others. And so that the blood level required to give you the needed anti-rejection effect is rather different. And so we are on a quest for finding a tool that can be individualized to a patient to measure their level of immune suppression. And we think that the measurement of some of these atypical viral infections might give us a handle on that. But just to let you know that when we started doing this work, it became very clear that in addition to human viromes that we could detect, there was also non-human DNA that could be detected in these samples. And when we dug a little bit deeply into it, we found that the vast majority of these non-human sequences were actually viruses, both single-stranded and double-stranded. And in fact, the most abundant was the adenovirus, which in fact has been associated with in HIV to be a potential for pathogenesis, but really has not been a real target for causing infection per se, clinically relevant infection in patients. And so when we started monitoring them, we observed a sort of a pattern in the change of the microbiome, which I'll show you here. And represented here in orange is the nanovirus. And so at the beginning, before at the onset of therapy, the largest proportion are the herpes viruses. But of course, we give antiviral agents at the beginning of the transplant to everybody. So with time, as I'll show you, the herpes virus load decreased. But what happened was that the anellovirus load really increased over time. And this was really very interesting to us. And what we showed that later on, as we were tapering off the immunosuppressive drugs, reducing it, the levels declined. So putting all that together, we began to ask the question whether the anellovirus load had some correlation and some relation to rejection. Put another way, could we distinguish non-rejecting from rejecting by virtue of the anellovirus load? And what you're seeing here is an attempt to do that. Anellovirus virons per human DNA compared tracked at months post-transplant, comparing the non-rejecting group of patients in blue to the rejecting, and clearly a very distinct pattern. And this raises the question whether the anelloviral load can ultimately be used and fine-tuned as a marker for the net immunosuppressive stage. And that's as far as we've got with that. And we hope that more work will be done in that space. So I've presented to you a set of studies and experiments that were done at Stanford from which we could make the following conclusions, especially about rejection monitoring. The first is that donor-derived cell-free DNA is informative as a non-invasive marker for acute rejection in heart and lung transplantation. That measurements of serial donor-derived cell-free DNA might permit earlier detection of rejection, and you saw those patterns of the curves where the levels rise before we actually make the diagnosis of rejection. And that this might be applicable to all solid organ transplants. And as I mentioned, we need to validate this further and then do clinical utility studies. Does this method actually help us to be more effective in managing our patients, especially compared to the current gold standard, which is the endomyocardial biopsy? Then as far as using the technology for microbes, the structure of the virome seems to be strongly affected by immunomodulation and antivirals. and in particular that the total viral load markedly increased at the onset of immunosuppression, and the anellovirus load might be enable us to stratify for rejecting versus non-rejecting. And here, the future directions, clearly we need to refine the technology, to expand this, to use studies, some mechanistic studies of immunoregulation, and so forth. Let me just end this talk now by talking about how we can bring this and leap forward to this idea of personalizing patient care. Can we be thinking about this of monitoring immunity, monitoring host defenses? There's papers that we've published on that. And can we actually use it to investigate racial disparities? And one thing that is very clear in the literature is that regardless of the organ transplant type, African American patients do less well after their organ transplant compared to other racial groups, and in particular to Caucasians. And for the longest time, the question was that it might actually be due to medication compliance, or even more recently to differences in drug metabolism. Well, a paper that we published last year suggested that it's neither of those, pointing to the possibility of there be a genetic basis to this, over and beyond the HLA typing. So more to come on this. But in order to do that, and getting back to the beginning of this talk, we need to be able to have large enough cohorts of various groups of patients to be able to study health disparities or health differences in outcomes. And this is why I'm so excited about working with the cohorts around the DC metropolitan area, because those that patient population has a lot more diversity, and we'll be able to study this. And when I got to NIH, part of the reason for going there, in addition to leading the diversity efforts, was to actually take some of this science and set it up. But I quickly realized that there is no organ transplantation at NIH. So in order to do this, I've set up a consortium of the 5 local centers that do organ transplantation, both heart and lung. True to form, as a cardiologist, we call this consortium GRAFT because we like acronyms, Genome Research Alliance for Transplantation. And this will bring together these centers to prospectively use these genomic technologies that I've described. And very interestingly, we'll be able to recruit in excess of 130 patients a year to begin to be able to do this work. And it harnesses the infrastructure of the intramural program where I am with the extramural centers to work in a very collaborative way to do this work. And just for your information, here are the centers: University of Maryland, Hopkins, MedStar, Washington Hospital, Inova Fairfax, Virginia Commonwealth. And we're all actively recruiting patients already and creating this biobank that we'll be able to do this work on. This work is quite challenging. I don't know whether you're following all the story about reproducibility with genomic research, how much of it is and isn't reproducible. So it was clear to me that the first order of the day would be to make sure that we can transfer this technology in a way that's reproducible. So we got some samples from the Stanford cohort where the sequencing had been done, the % donor-derived DNA had been calculated, and we run it through our own systems to compare what the results would be. And you can see here an example of one patient is that there's absolutely almost superimposable results. So we're quite confident that the technology has been transferred. Another challenge is actually getting the technology to be able to be be reported rather rapidly. We can't be waiting for a week to determine whether a patient is rejecting or not. It has to be a turnaround of within 24 to 48 hours, and there are a number of facilities there within the NIH that we have access to that will help us to be able to ramp this up, including automated high throughput nucleic acid isolation, the automated library formation, and next generation sequencing. And so that we will be able to not have to do a lot of this manually and rather use robots. We've already begun to do that work, to compare it, and you can see that the results using the robot, in fact, are very good. We're very pleased with that. So our future agenda is that we want to study the genetic basis of the different outcomes after solid organ transplantation. I think this is going to be very exciting work. In addition to nuclear-derived DNA, there's mitochondrial-derived DNA, which I didn't have time to go into, which again could be measured and could be a very effective way of tracking patients. Strategies for identifying organ-specific oligonucleotides, we're doing that, and that will then push this work into the broader space of injury to all other different kinds of organs. Again, miniaturizing these technologies and having them as point of contact will be the ultimate goal if we are going to really be successful in this arena of precision medicine, which was the basis of this talk. I showed you a lot about the issue of the vascular injury and the vascular damage that limits the long-term outcome. How can we better diagnose it? We believe that a lot of the damage comes from endothelial-derived donor DNA, and it's a marker of that, and perhaps linking up with other technologies that non-invasively can measure the vasculature, such as cardiac MRI, might be helpful for us in the future. I also pointed to microbiome and that work that we're doing, and then the link with immunology and the B and T cell repertoires, which we've already have published preliminary data, is there. So let me just close by acknowledging our collaborators, the clinical team, very critically important, the supporters and the providers of the money to do this work cannot be done without those resources. The collaboration that comes from collaborating with bioengineers and clinical researchers, I think, is critical to move this work forward. But I think the heroes in all of this is our patients, and I always like to recognize them specifically. And this is the team in my lab and the other collaborators in this new area that I'm working at NIH. And I thank you all for your attention. I'll be happy to take questions.
Good morning. Thank you so much for your lecture. One of the conundrums in management is the mildly symptomatic or asymptomatic patient who may have a positive test result, and whether to biopsy and how to manage that patient.
Thank you very much for the question. The question is that one of the conundrums is the patient who might have just a mild rejection on the biopsy, and how to manage that, especially in the context of diminished organ function. So I think through the years we've come to recognize that the clinical diagnosis takes precedent over all of this. And I would say that in a patient who obviously has significant graft function dysfunction, particularly heart dysfunction, it's an immune-mediated decline in function until proven otherwise. And for many years at Stanford, I would be faced with that. And we did not have the diagnosis of antibody-mediated rejection, which is now the second thing that you would look for following cell-mediated rejection. And I would treat them as though they were rejecting, first with high-dose corticosteroids, and secondly, even with plasmapheresis and some other therapies, ATG and so forth. So in summary to your question, I would say be guided by the clinical presentation of the patient, always going back to that, knowing that the currently available tests are not 100% foolproof. But when this technology comes on board, I think what it's showing is that we might be picking up positive, elevated levels of donor-derived DNA before we see anything happening in the patient. And the question is what to do about that. And I think we'll need to study that. I would hypothesize that that actually means early injury, and that we could likely intervene earlier by minor increases in the immunosuppression that would make a difference ultimately to the outcome, rather than those mammoth doses of corticosteroids that we use. And ultimately, we'll be able to have better outcomes. So that sort of set of hypotheses will need to be tested.
You mentioned the issue of organ-specific DNA. And because what you're looking at is a ratio of donor to recipient, if the recipient also has dysfunction of another organ, it will affect that ratio. Let's say you had cardiac rejection and you had secondary renal disease. Can you talk a little bit about how you're going about that? Because that seems like a very important line of research. Great question.
The concept of organ-specific sequences has just begun. We have some preliminary data from 2 weeks ago, which I wasn't going to present to you. But I think it's a very important question to be thinking about. But I would say that what we're looking at donor-specific, truly is donor-specific. There will not be those sequences ever coming from the recipient. And that's the beauty of this test at this time, in that we're pretty confident that what we see as the sequences that are really coming from the donor and not the recipient. The question is around whether or not detection of mitochondrial DNA has a different implication to detection of nuclear DNA. I don't know the answer to that question. They are very different sequences. We are hypothesizing that early injury will be detected by damage, mitochondrial damage, and spillage of that mitochondrial sequences into the circulation. But the characteristics, as you probably know, of mitochondrial DNA are very different from donor DNA. They're shorter fragments and so forth. And so we will be able to tell what we are looking at. Are we looking at mitochondrial, or are we looking at nuclear DNA? Then we'll be able to answer some of those questions. Yes, that's a great question. The question is, what is the relative contribution of different cell types to the DNA that we are measuring? We don't know yet. We haven't done those studies. I think they're highly, highly relevant. I suspect that much of what we're seeing in the heart is endothelial-derived. And that is why we are particularly interested in figuring out whether or not the amount of damage as measured by cell-free, donor-derived cell-free, has any relationship at all to the allograft vasculopathy. That's where that string of thought comes about. But we haven't yet looked at that. And this is sort of the exciting part of this work. The question is around whether or not the use of the microbiome might be further studied in other areas as a measure of the immune state of immunity. No, it hasn't been. I'm not aware. Certainly when we published the paper in Cell, that nothing been in that arena. I think it will be a very exciting and fruitful area. In fact, as we've set up the collaborative, the graft consortium, internally within the intramural program, there are a lot of investigators who are very interested, particularly in this field, and with this large biobank that we'll have, we'll be able to begin to study that. But I think it should be studied out there by, experts in the field as well.
I have a question about your first case that you discussed. I guess, first of all, do we know the genetic cause of the cardiomyopathy that the patients had?
No, we don't.
Okay.
We don't. She was diagnosed now, let's say, 25 years ago, before a lot was known about that. So we didn't go into that. I know that colleagues at Stanford are looking into all the different genetic types of cardiomyopathy, but this one was not studied, sorry.
And the second question is related to the pregnancy and the fact that it seemed to contribute to the rejection, and I guess what is known about that, and is that something that happens frequently?
Yeah, well, it has always been anecdotal that when during pregnancy, somehow by some mechanism unknown, there would be immune activation. So it was a bad idea to even allow patients to have children. This is the recommendation that we gave, and thankfully a few patients did not pay heed, and then we discovered that in fact they could be managed quite well and do extremely well, like you saw this patient. But it is intriguing that you could the patient does mount antibodies. I think that HLA, what we discovered in this patient were HLA-driven. It was due to the discordance in the HLA type between her and her husband relative to the first graft. The work in that field, again, is there is really not that much at the moment. I think most of it is around HLA disparities, mismatches. But now, of course, that we have the genomic tools, we can very much figure that out, couldn't we?
Yeah. I guess pregnancy can be seen as sort of a transplant in some way as well. All right, I'd like to thank Dr. Valentine for an excellent presentation. Thank you all for coming.